complicate all the hormonal things, but we're going to make it easier. And again, I want you guys to remember things after this, okay? So, and first of all, we want to understand why it is important that we need to preserve these parathyroid glands, okay? So let me just go through the things here and through the basic ones, and let me just try to make this work, okay? Because my presentation is just, okay, let me go there. Okay, so probably this is gonna work this way, and I'll pass it my way, okay? So basically my disclosure, as you know, I'm an ENT, but I'm also the Medical Affairs Director Medtronic, and let's keep on working on this. Okay, let me see if I can pass this on my own. And that's gonna be the overview of what we're gonna do here. And we're going to discuss this in order to understand and remember it, okay? So we'll take around 45 minutes to go around all of this, and I will try to use the last 15 minutes or more for Q&A, okay? That would be the plan that we're gonna follow right now. And let's jump into what we think it is the key and fundamental concept here. So why calcium? And I know it sounds very heavy, very dark to start this conversation. We are surgical guys, but why the calcium is so essential? And calcium, and what does it do in our body? So we use many elements in the body to do fundamental things, but calcium is essential to life. And is used primarily for three things, okay? First, it provides, as it says here, provides the electrical energy for our nervous system, okay? The most important thing is that calcium is what the nervous system of our body uses as conduct electricity. That is why one of the most common symptoms that we will find whenever we have parathyroid disease, because now you're gonna relate parathyroid with calcium, one of the most common symptoms we have, it is related to the nervous system. We might find in the patient's depression, weakness, tiredness, and it happens because the calcium blocks the sodium channels, and that's part of the way it does its effect. So it provides a strength to skeletal muscle. Everybody knows that calcium is used to make our bone strong, but this is just half of the story. And see the bones like a deposit, okay? The bones themselves serve as a storage system. And we use them to supply the calcium, okay? Just like a bank, imagine a bank, we constantly make deposit and withdrawals, and we're constantly putting calcium into our bones and constantly taking calcium out of our bones in small amounts. But see the bones as a storage, okay? And the sole purpose of this is keeping calcium levels in the blood, you know, using this storage that we have. But remember, the most important role of the calcium is to provide the proper function of the nervous system, not to provide strength to our bone. That's totally secondary as a function. It is also critical for, okay, muscular contraction, okay? It provides electrical energy for the muscular system, just like the nerves in our body, our muscle use changes in calcium levels inside the cells to provide this energy to contract. So when the calcium levels are not correct, people start feeling like weakness or cramps or these kind of side effects typical that we might find. So this is a concept that we need to understand, that we have then normal levels that are allowed, and we need to have those normal levels in the body. And normally they rank between 8.6 to 10.3 milligrams per deciliter. And this is a very, very narrow range. It means that we have to control the calcium in a very regulated way. And let me give you just a concept. We have in our body around 2 and 3.5 pounds of calcium in the body. 99% of this is in bones, and 0.1% is on the fluid, the extracellular fluid, and the serum, the one we're gonna measure, okay? And when the blood levels of serum of the calcium are low, we call this hypocalcemia, which is the lower part of the diagram, and above those levels are hypercalcemia. But they fluctuate with the age, they fluctuate with a lot of things too. So we're gonna jump a little bit into one of that. And calcium is in our body in two forms. We can have it as a mineral, and we know it is stored in bone as a mineral, And, there are critical areas on those bones where we store a lot, like a humerus, femur, vertebrae. But we also store this, or we have this is not stored as a calcium, as a salt. And part of this salt is going to be bound to proteins, like 40%, but most of that part is going to be ionized. And the ionized part of the calcium is the one we're going to measure. That's the one that is floating in our serum. So again, try to understand that we're not really measuring all the calcium. We're not measuring all this amount of critical calcium that we have in the body. We're just measuring the one we have ionized floating in the serum. So that is important to understand, because that is what is going to bring us, the perception of what we really are dealing with and using with. So let's talk a little bit about the parathyroid glands, okay? So effectively, these parathyroid glands are 4, okay? Time to time we joke and we say they have 4 because in case you receive 3 penetrating injuries into the neck, you will get the 4th one working. But basically, yes, you can work with one of them. But the truth is we got 4, and I believe it is a very way and sensible way to measure the calcium we have around the body. So these 4 small endocrine glands regulates the calcium in our body, and they're located in the neck behind the thyroid, and the role is to continuously monitoring and regulate the blood calcium levels, okay? What else can we say? Well, there are very, very small glands, okay? And they have these size. They have the size like a pea size. They weigh around 30 milligrams, which is a very, very small amount. And basically, I want to bring you all these concepts because whenever we're going to jump into surgery, every single thing that I'm saying right now has a weight. They're small. They're behind something. They're in a very crowded place, which is the neck. The surgical neck is one of the most difficult areas to operate. And they have a very fundamental role in, the neurologic system, because they have to regulate the levels. We have a system of storage. Everything has to be and considered as an important fact, okay? And they produce that parathyroid hormone, okay? And that's a very important concept too, that you can live with just 1 or 2 of these parathyroid without having big changes in your system. So let's get a little more anatomical here and try to understand that they are generally identified by the position, shape, size, consistency. And we know as surgeons that, they have a very characteristic thing. They blanch whenever we press on them, on its surface. They look pretty much like fat, but they don't float like fat. So these are kind of things that we know as surgeons on the practical side. But let me go to more academic things. And I looked some articles around the anatomy, and in 84%, we have 4 parathyroids. But in 13%, we have 5 parathyroids. So again, you might have more, and sometimes we have 3 of them, okay? And their anatomical relations, as you see, are the back of our trachea. So we have their relations with the tracheoesophageal groove. We have relations with the posterior aspect of the thyroid gland, which is in the extracapsular area of the gland. We have the recurrent laryngeal nerve, and we have the thyroid arteries, which are the superior and inferior. We're going to talk a little bit more about these arteries. And these are the common locations I just put here to try to show you that, as you see, they're on the back of a gland. They're very small. They have a very important function, and they don't have a typical location. They have a lot of variance, okay? In some series I was looking at that, 95.7% of the superior parathyroid are very constant in their position, but the inferior parathyroids they derive from a different brachial pouch, okay? They come from the thymus. They come from very far in the embryologic life because they come from the base of the tongue. And the 2 inferior parathyroids might have a lot of variance when you have to locate them. So the upper parathyroids are more constant in their position than the lower parathyroids, okay? And we will talk about that, and we will see some statistics around that, okay? I just don't want to get too deep into that, okay? And here you have, these are some uncommon locations parathyroid glands. They could be an undescended in 1% of the case, inside the carotid sheath in 4%, inside the thyroid in 10%, around the esophagus in 60%. It could be inside or at the level of the posterior mediastinum, and with the thymus in 25% in the anterior mediastinum. So basically, they have a lot of variants, as you see here. And again, this shows the anatomical distribution varies since the superior parathyroid is derived from the fourth pharyngeal pouch and the inferior parathyroid is from the third pharyngeal pouch. So the inferior migrates with the thymus from further, so there might be more than 4 parathyroids in 15% of the cases. So these are just anatomical things, but just take that idea. Variants, they're deep situated. They are more inconstant in their position, the lower ones. And see the relation that we have around. As you see, they are surrounded by these vascular and neural branches that we have here. Venous, arteries, and nerves are around those areas. So this is an important thing that we have to give. Another concept I want to give you, because it has a lot of consequence when we do perform this surgery. And as you see here, we can find that, I would just summarize this saying that 75% of the vascularization of the parathyroid depends from the inferior thyroid artery, and the superior only vascularize around 15%. I know there is a plexus and they join the inferior and superior thyroid artery. They get together at some point, but the dependence is a lot higher. It's 75% against 15%. So that means that if you have time to time to take a decision and have a vessel that you have to sacrifice, well, it would be better to sacrifice the upper branch of the thyroid artery than the lower branch, because it is more relevant to the vascularization of the parathyroid glands, okay? And again, it's not like a big branch. I don't know if, let me see if I can show you here. It's hard to show you, but these are very, very small branches, and these very small branches can be damaged very easy. When you're doing thyroid surgery, you use, it's a very bloody surgery, and you want to keep the field clean. You use suction. Somebody's trying to pull. It's on the back of the gland. Somebody's trying to pull. And time to time, you don't have to resect the vessel. It's a very small vessel, the one that branch into the parathyroid glands, and you can collapse those vessels, okay? There's some statistics that shows that 38% of vessels that supplies the parathyroids are under risk in a standard thyroid surgery. And we know, and we're going to talk that. I just want to prepare you guys to start hearing hypocalcemia, so low calcium. Now you know what are the values. Hypocalcemia is the most common complication and can be as high as 30% in a common thyroid surgery. Obviously, statistic, experience of the surgery, et cetera, the kind of pathology you have, a lot of things may change, but it could be at 30%, okay? So you can get hypocalcemia in 30% of the cases whenever you're dealing with a thyroid surgery. So that's an important concept to keep in your mind. So I'm going to show you here. Well, that's a surgery, a regular surgery. And here we're seeing this is the right side that came from a surgeon that exposed this surgery. That was on a papillary carcinoma. This is the right side. And he's dissecting, this is the isthmus in the center. And he's dissecting, obviously trying to separate the isthmus, which might get the contrast too. And at some point, I just want to show you a few of the things here. Here you have probably a little before that. Here you're dissecting here. Okay, that lobe being dissected here can show you, here is the plane where you are dividing and dissecting the gland from what you have on the back. And here you have some of the branches, okay? That's the right superior parathyroid there. Let me just show you a little, we don't need to see. That is a nodule, a metastatic nodule. And here we're dissecting and separated, okay, because it is attached to the recurrent nerve, which is the white thing you see on the back here. It's a white thing. So you need to dissect. Here you see in the recurrent nerve, dissecting the whole thing around there. But again, it is time to time hard to differentiate. As you see in this view, it's very hard to differentiate what is fat, what is parathyroid. Here you have a parathyroid gland, but you see it's very similar to the rest of the structures that you have here. You're dissecting here on the opposite side, and here you might see, okay, what is the parathyroid gland, what is the nerve here, and again, it looks pretty much like fat, okay? It is, you know, it has a color that has been defined like brown mustard. That's the way it has been defined, that color. Here you see the recurrent laryngeal branch, okay? And let's see, that was a video, very nice, very clean, but that's not the case. In most of the cases, you will see a bloody surgery, and it's time to time, the identification with the naked eye is not very reliable, okay? Most of the experienced surgeons says that there are around 40-something% that they can identify the gland with naked eye in regular cases, but time to time they don't identify the parathyroid glands, okay? They look very similar, as I was saying. They look like fat, even with magnification. And again, remember, the patient has more fat, okay, it's more complicated. If the patient is older, he got more fat also in that compartment, so it's even more complicated. And, you know, there are times when we have to sacrifice the parathyroid glands because the pathology don't let us, you know, to keep that gland because it could be harmed. And just to, sorry, let me just go back to where we were. And here we have, okay, that's a typical view, and that's a real view. And as you see, look at the gloves. They're full of blood. These are bloody surgery, okay? And as you see, after the thyroid surgery, one of the most frequent complication after this is the hypoparathyroidism, okay? And it's obviously related with the vision of the surgeon. If it's a bloody field, obviously you're gonna get an increased risk factor, okay? You don't want to damage the feeding vessels, even if you keep the glands, but you damage the vascularization, you're going to have a problem on there. And there are some risky areas that we know there are typical areas, like this central compartment, what we call the sixth compartment. This is a typical area where we get, whenever we get, you know, into that compartment, we have lymph nodes that we have to treat on that area, which is very common there. This is exactly where we damage the vascularization of the parathyroid. There's a rule that, remember, that I learned in the school. It says 70% of acquired hypothyroidism is post-thyroid surgery, 75%, sorry. The rule says that 75% are women, and the rule says that 75% are more than 45 years old. That's the 75% rule that I remember. That's an old rule. I'm not sure you have to update it, but that was in my time, okay? So I put here a case that you see time to time. You know, this is a typical cancer. Okay, that's an aplastic carcinoma, and in this case, as you will see, this is, you know, obviously something that you see in developing countries. But the kind of things is that these cases, this woman had obviously to complete that a laryngectomy. You see resecting the sternocleidomastoid muscle. And here you're not going to preserve anything. These are the kind of cases that you take everything away. So I love the elegance that we can keep as surgeons whenever we can preserve the anatomy, but sometimes we get too late and the staging is too high for that, okay? So let's take a closer look into the parathyroid gland, okay? We just try to keep on time. Okay, so if we take a look into the parathyroid gland, this is the way it looks in a histologic cut, and you will see there are two types of cells. Basically, remember the typical two cells are the chief cells and the oxyphyll cells. The chief cells, they produce PT, okay? They produce parathormones, okay? The parathyroid hormone, okay? And these are the key. And the oxyphil cells, they stimulate or they regulate the chief cell. And you have a lot of adipose tissue on around those glands, okay? That's a typical thing, okay? If you take a closer view, you will see, you're seeing those vesicles, those follicles that are full of hormones around them, okay? And you can put some contrast and different colorations, and you will see them even better and better. And now you see the difference between the oxyphil cells and the chief cells here, which are very good. But I don't want to bother you guys, but I just want to give you the idea. Take a look on the right video that we have there. There you have on this curly thing, you're seeing the calcium getting into the sensors of the parathyroid. And as we have calcium there, you see that is shut the release of the PT. But if you don't have PT, you will release parathormone. And that parathormone will do a lot of effects. I just want to summarize some of these effects because the basic thing is that the PTH, the parathormone, acts in different areas. Essentially, it goes to the bone, okay, and it stimulates some cells. We're going to look around that, what we call the osteoblast. Osteoblast talk to the osteoclast, and we'll look at that. It goes also to the kidney and also to the GI tract. And we will see why it will be so important in each of these areas to preserve calcium. And time to time, this PTH hormone also acts. I mean, what happens to the calcium will happen the opposite to the phosphates, okay? So phosphates are going to go down, calcium is going to go up, okay? So let me show you here what I like very much on this picture. And basically, I'm just going to summarize. PTH is what the parathormone. Whenever it gets into the bone, so you're seeing from on the back, from left to right, the different ways the reabsorption of the bone can happen. What we call on the right, this is osteoporosis. What you see on the left is a normal bone. And PTH gets into some of the cells that you have on your bone, which are the osteoblast. The osteoblast send a signal, which is called the rankle. Rankle stimulate the osteoclast, and the osteoclast start reducing the hydroxyapatite and start taking and breaking and opening that calcium that is inside the bones and releasing that calcium into the serum. That's why when you have high PTH, you start taking away the calcium from the bones and bring it to the serum. So that is the concept that I want you guys to catch in here, okay? So that happens at the level of the bone, okay? There's another substance that does the opposite, and it's secreted by the it's the opposite. It's what we call the calcitonin, and the calcitonin does exactly the opposite. It regulates in the opposite way of the PTH, okay? He will decrease. So it's a way of tuning very good the levels of calcium between one and the other. But again, calcitonin is related exactly to the same area. So you have on the left what happens in a pelvic and femoral hip. You see here an osteoclast activity. You see that bone, which is totally demineralized. You see that it has a lot of contrast between dark and light. And you see an osteoblastic young bone on the right. So you see the difference, and that's, why, it also is related to other factors like estrogen activity, a lot of things. But basically, this is a difference between two very drastic differences in scenario, okay? On the other hand, it also has an important role in the kidney, and in the kidney, it helps to reabsorb the calcium from the kidney, and it helps, the parathormone is also losing in the kidney. With the parathormone, you save calcium, but you lose phosphate. When you have, I'll talk later on that, some vitamin D derivative, you will save some phosphate. So the balance will be to have a correct vitamin D situation too. So that's exactly what this talks about. So you have a pre-vitamin D, okay? You have two forms of vitamin D, ergocalciferol and hydroxyferol. So both of them They will help on the synthesis to make D3. D3 will be part of what activates what we call the calcitriol and will reabsorb also calcium and phosphate from the kidney. I don't want to jump too much in that, but now I think we better understand, or at least we have the concept that calcium homeostasis, the level of the calcium, is a very complicated to keep it under balance. And a lot of things happen in here. The GI tract helps in the absorption, the kidney, the bones, but PTH is key to be involved in all this process. So now you understand that those, try to correlate what I'm saying, those 4 tiny glands that you have on the back of the thyroid can make a mess, a big mess, because around all this reabsorption of the calcium, which is key now, and the calcium works for everything as a neurotransmitter, imagine what we can do then. So how I'm just going to give you this because that's going to be key to understand for the next, now that we're going to jump into the preservation of the parathyroid. We need to have a rationale to understand that the normal range here, it is plotted, the blood calcium level against the PTH. And you see this is the square on green that shows you exactly what are the right levels. But you have other things that you might see, what we call primary hyperparathyroidism. These are the typical things where the gland start producing a lot more PTH. And here you will see, if you sample the blood, you will see high PTH level and again, high blood calcium. This is what it's showing this graph. But if you have, for instance, a high calcium malignancy, you will see that you will have a low PTH level, but you will have high calcium level. So we will talk, these are values that I want just you to know that there are circumstances where our graph changes. If we have, for instance, low vitamin D, we will have almost a normal range of PTH, but a low calcium level, and so on. If we have kidney failure is a key, kidney, as I said, is key for the reabsorption of vitamin D. And if we don't have vitamin D and we don't have calcium and we have all these elements, that's going to be part of the problem. So we're going to get some other scenarios. I don't want to be too complicated here, but just to give you the idea that we have, if you have a gastric bypass, for instance, it is where it is inserted in the curve. Okay, so let me go, and remember the rule that I said, 70, that's not 75, guys, sorry, it's 40, 75, yes, post-surgical, 75 females, 75 around 45 years old. Yes, that's correct, okay, so that I even change the numbers. Okay, good. So quick facts that happens post-thyroidectomy, hypocalcemia. How often after a regular thyroidectomy you get it? Incidence, it's very high. Incidence, acute incidence, means just right after you have a thyroid surgery, you can have between 19 and 38% of the patients having a low calcium level. But that is going to be corrected in the next weeks, but it could be permanent in almost between 0 and 6.5%. That's very high, okay? And it starts 24 to 72 hours after the surgery, okay? How do you track these patients? Well, they're going to have some paresthesias. Paresthesias are these sensations that you may have around the oral area. You can have also weakness, headaches, and some cramps, laryngospasm, and on the EKG, you can have some arrhythmias too. So that is something that it is important to note it here, okay? And it has some incidents. Healthcare costs, testing, electrolyte supplementation, hospital stay, that's something that affects. Long-term, you can have chronic renal impairment if you have damage on the parathyroid, reduced bone remodeling, and you will see psychiatric complaints, basal ganglia calcification, cataracts, and on the numbers that I look, inadvertent parathyroid gland removal, it happens between 8 and 19% of the cases. You will see on the right, this is what we call Zvostek sign. When people have low calcium and you touch and you tap around the facial nerve, one of the branches, you see that contraction on the face, which is homolateral to the side. On the medium, the Trousseau sign is when you use some pressure on the arm, whatever, you can use anyone, you will see that internal contraction of the hand from the inside. That's what we call the Trousseau sign. And you have also on the EKG, we have the QT prolongation. Okay, you can have AFib too, fibrillary auriculation, atrial fibrillation that could happen also with some hypocalcemia, high hypocalcemia levels. Okay, that's something that you have to consider. So, what are the goals to avoid this? Well, obviously, when it happens, we have to ameliorate those symptoms, and we know there's some risk in some of them. Okay, we have to try to sample and know that we have the normal serum calcium levels within the normal range. But remember, serum goes in one sense, but phosphorus goes in the other way. So we have to keep those levels, both of them, in a normal levels. We have to avoid hypercalciuria, because hypercalciuria means we're secreting a lot of calcium, and we can have stones. Okay, now we're gonna have some stones that will produce, now we're gonna have some problems on the kidney. So we don't want to jump into that secondary problem due to the release and the loss of a lot of calcium. Okay, so what happens? I'm just mentioning this because you've heard about that. We can do an auto transplant. Okay, it is something that was long time ago. In 1926 was the first time it was done. Okay, and you can put it into the sternocleidomastoid muscle, pectoralis majoris, brachoradialis, subcutaneous, a lot of places, and it has worked in more than 90% of the cases. It works pretty good. Okay, but again, you're transplanting something. It's not, you want to preserve. And if you can preserve and you know where your gland is, this is key, to do the correct things. Okay? So what is the planning? Okay. So the planning normally, as you've seen, guys, whenever you go to a thyroid case, everybody has, most of the time, you have a CT scan, a high resolution CT scan where people try to find out exactly what you have there and to find where the tumor or the mass is. For the parathyroid, it is, the sensitivity to locate. Let me go through the different methods. Okay, the high resolution ultrasound has a sensitivity of 21%. That's pretty low. Okay. You don't want to rely on something like that, and you need to be really an expert in order to use it. CT and 4D CT has a sensitivity, but again, it's a very limited sensitivity. And as you know, most of the authors that are, most respecting this field and they want to really find out how to preserve, they use this 99M technetium sestamibi, and that's a very, it's a scintigraphy that has the highest sensitivity. But again, it's 54%. But you can see them, and that's if you combine it with the SPECT, which is super expensive, now you have a lot more sensitivity. But again, we need to balance. Not all the cases you can do that. Okay, so you might be unable to localize, okay, and not to correlate with your pathology. So that might be part of it. So, I remember on my own, and when I used to do head and neck surgery, I remember that most of the time you knew it, that you took them away because the histology guys was telling you, okay, you have here part of your parathyroid, and I was not expecting to have it there. Okay, so it happens a lot. Okay, it is, and I believe there's a lot of technology going around today, so you don't have to be like the way we were a long time ago. Okay, so techniques to identify nowadays the parathyroid gland intraoperatively. Okay, we have these intravenous injections of methylene blue and aminolevulinic acid, which is technically obsolete, but I've heard some people still using. You have levels of PTH. You have to sample every 5 minutes. It's not exactly something that if you can, it's complicated. You can have frozen section, okay, and aspirate. You have the technetium 99 with sestamibi, that's a radionuclide, okay, and you have the autofluorescence, which is probe-based, like the PTI, or image-based. So we have these two options. Okay, I'm going to talk about, what we have today. So what we do, autofluorescence and radionuclide. Okay, why each one? Well, let me put it this way. PTH levels and pathology take time and elevate cost. Okay. Yeah, it's related to surgical anatomy in real time, and it's more effective and sensitive. That's why we think it is the way to go. So let me just mention this indocyanine green. Okay, it is a fluorescent method. We need to know about it. You've seen that in surgeries. Okay, but it's not autofluorescence. Okay, so you have to stimulate that. Okay, so it is an expensive, very expensive. Okay, the contrast, the indocyanine. You need an IV administration. It requires a special equipment. You need to see it. So you need filters, lenses for special cameras. It's iodine-based, so it creates allergies. And for us, it will concentrate in thyroid too. So, again, if it's iod, it goes to the thyroid too. So, again, you're trying to see something that has a differential with the thyroid, not exactly something that is going to also be absorbed like the thyroid. And, well, it has been used, yes, for flap perfusion when we do some reconstruction flap, and we want to be sure that the flap has a good vascularization at the end of the surgery. This is where I see the useful of this, okay? Now let's talk about this NIRF, okay, near-infrared autofluorescence. Well, it is basically based on something that we know from a long time. I personally have some experience with the diode laser. I use it in my office for years, and we even have one in each office. Sometimes we were very excited with the good, work that the diode laser does on cutting and coagulation. So we use it for biopsies in the office or whatever. But basically here is a totally different concept. It's this NIRF, it's going to be used for, it has a light, or what we call autofluorescence, that is between 785 nanometers light. So basically, this is something that has been shown that the parathyroid gland have an intrinsic ability to autofluoresce at 785 nanomilligrams, whatever, nanometers light, okay? So, and it's, as you see, it's a totally different the absorption that you have with the thyroid. So just take a look on this graph. I like very much this fluorescence intensity and the wavelength, and you see how the parathyroids have a totally different absorption of fluorescence intensity that has the thyroid, the muscle, and the fat. And this is a probe, as you say, it's a probe base, okay? And any reading, you put the probe there, and the fluorescence occurs between 800 and 1,000 nanometers, okay? And you will see that any reading above 1.2 is parathyroid tissue, and you will get the signal that the PTI will tell you that you have them there, okay? Here, I just want to show you here the way it looks, okay? The probe captures, as you will see, the way the probe shows, and that is sent and processed by the console, and you will get the signal, okay, and you will get the information. Okay, you're going to be experts on this. Okay, what are the benefits of this autofluorescence? Well, remember, 46% of the parathyroid glands are not visible to naked eye. This autofluorescence detection is between 97 and 99%. Obviously, it has less fluorescence if you have a high BMI, and 50% less if you have hypocalcemia, and 10% less if you have severe hypocalcemia, but you still have a differentiating aspect between the rest of the gland and what you will have. I didn't have much more information and neither experience. I'm just talking theoretically on all these studies that some people have done. This was, they enrolled 20 patients, and they were evaluating, if it was a probe-based or an image-based way to detect the gland. And that was the question that they had, the different methods. Okay, here we have the typical NERAF detection with the probe, the PTI from AI Biomed. And this is the way it displays on the monitor. And this was a publication from 2019 from the Journal of Journal of American College of Surgeons. So if you compare image-based with probe-based, one is qualitative, the other one is quantitative, one is visual, the other one is auditory. What you got the signal, distant to target, you have difference, ambient, you don't need, it's a probe-based with a normal light. Cost is a lot lower in a probe-based. And you know, what I mean by aesthetic, in the image-based, you will have a texture, as I put here. You have more colors in your monitor, and on the probe base you have a more plain thing. But you are totally different things. Whenever you evaluate all surgical fields, there's a big difference. And as you see, identify, you know, the parathyroid gland in small, challenging surgical cases, both of them. The image base might evaluate the perfusion. The probe base won't do that. But I just want to throw you some results that we have here. And these results are pretty interesting because sensitivity, if you compare the image-based systems against the fiber probe system, you see it's something like between 80 and 90 on image-based against 97%. And specificity, it's also very high. So accuracy, obviously, the result of all of that, it's around 92%. And this is basically some of the things that I could found in some of the publications. And when is the clinical utility to use this autofluorescence spectroscopy? When you do a total thyroidectomy, so you want to preserve the glands, or you have a previous thyroidectomy and you want to see, you know, you may have an irradiated gland or a post-surgical condition, and this is where the anatomy has changed a lot. This is when you need extra help for that. When you have a central neck lymph node dissection, when you have, parathyroid procedures per se, or with, surgeons that might need some extra support in order to find the exact location of the parathyroid gland. So in conclusion, I would say, and okay, I'm on time, okay, 44, okay. So this is for parathyroid detection, and I think it's a valuable adjunct, okay, way to identify. Probe base is a lot more sensitive and accurate, okay, but you have information. It has the information it has to give. It can use in normal light, which for us surgeons, it's very important, okay. And you don't need a big expertise to use the PTI, okay? Apparently, and according to the experience that I've heard, is a very easy and way to use it. You don't need any big experience on the technological side, okay? So basically, that is why what I was gonna bring to you guys. And I think I will have these last 15 minutes. I think I haven't missed anything around you here. And I think it's time, Stephanie, if you want to have some questions. I was just trying to show you the plan, the whole plan that we have here, the overview of what we talk about. Okay. So Stephanie, let's open the questions. If we have questions, we can, probably talk again about some points, anything that you might need.
Yeah. First off, thank you very much. That was really good. I learned a lot as well. We have had a lot of questions come in, and I think you guys are clearly excited to learn more about PTI, and we will get into that at the end of the month. On all of the details. I'm writing down all of your questions. We won't be able to get to all of them technology-wise, but we're going to give it a shot here. So let me go back up here. Eric asked, what's the percentage of false positive false positives for each technique stated above compared to PTI. So can you talk about false positives when identifying parathyroid?
Well, that would be a good question. And again, let me introduce something that I have missed. Sorry, guys. And sorry, David. We have with us the product consultant for AI Biomed, which is David Mills. David, are you there? I'm not sure if he's there because David Mills, well, yeah,
we'll probably have David on. We're going to have him join us for training. I don't want us to get too deep down the rabbit hole on the technology. I want to stick more to anatomy here.
Okay. So I'll keep the answer more related to the cases, not totally related to the AI Biomed, okay? And again, that goes back to what I mentioned on one of the slides. One of the things that we have, and most of the time, is the identification issue. And the identification issue for us, it is something that, we don't identify the gland in many, many cases. And numbers, to give you some numbers that I dropped to you, I would say that you normally, depending on the case, but you identify the gland with the naked eye in around, you can jump around 25 to 30%, depending on the experience of the surgery. But when most of these cases are carcinomas, and they fluctuate. There are 4 big carcinomas in the thyroid. Okay, if it's obviously a papillary, it's a very simple thing. Is a follicular, it's a little more complicated. If it is an anaplastic, you will not identify it. And when we have these parafollicular cancers, which are the medullary cancers, the ones that secrete calcitonin, these are very complex cancers because they are multi-endocrine cancers. So I would say, let's keep that number around 20%. It's easy for a medium surgeon, around 40% for an expert surgeon. Okay, these are the numbers that I would say with naked eyes. Okay.
Let's see here. So are they testing for PTH right after they come out of surgery? The PTH levels?
Yeah, they are most of the surgeons. We do that. Okay, well, they do that. I mean, PTH is one of the most sensible things that you can test, but PTH alone is just your level of PTH will be exactly what your calcium level is going to be a little later. So you can work both ways, but PTH is the most sensible way to predict and not wait to get calcium or phosphate levels later on a problem. So yes, PTH, and some surgeons just use PTH sensor and they just test, during the surgery, they start sampling PTH at least 4 or 5 times during the surgery. It happens, that's more the old school, and that's, but PTH at the end of the surgery is part of the things you do routinely, yeah.
Okay. I think that sort of goes along with this next one. Does PTI reduce the need to perform calcium lab draws intraoperatively to determine systemic effects of parathyroidectomy?
Exactly. And remember, you can see the PTI, as a tool, obviously, that will help you to improve a lot of things that, let me put it this way. Nowadays, it's very expensive also even to identify the lesions, okay? Whenever we have to do a technetium 99 with sestimibi, it is very, very complicated, and it is because we know that during the surgery, we're going to be lost. Probably we're going to reduce even the complicated preoperative studies because we will have ways to see easier, and through the thyroid tissue, we're probably going to be able to see part of the parathyroid gland. So probably on pre-op, per-op, and post-op, we will improve a few of the things that we're doing nowadays, okay? Not as much routine exams, and we will be more targeted.
Okay. What do you think reps need to know from an identification standpoint to help support customers during a procedure?
Okay, well, probably the message I passed to the reps today was horrible, guys, because I told you, the two upper ones, how are you going to find them? But the lower ones are more inconstant. And time to time, they're on 4, they're 5, or they're even time to time less than 4. So, yeah, the message that I want to give you, probably, it is not that constant where we can find them. There are things related to the normal embryology, which are not constant, and there are things related to the pathology, which might change the location of where we're thinking about. One of the things that I want to give you as an example, that typical thing, the damage to the parathyroid doesn't happen sometimes just, damaging the gland per se. It happens because we ligate vessels or we go around the parathyroid. Even if we see the parathyroid, we have somebody who's helping us during the surgery and is really doing some very aggressive gesture that might create some ischemia in the gland. So my point is, what can we do there as to help? Well, the element that we're bringing to the table right now is we want to visualize something that has been very difficult to visualize, that has been inconstant in the anatomy and can have variants. We probably have a way to visualize in a more clear way and to preserve it. That is probably the message, because telling them, okay, the upper one is very related to the superior branch of the recurrent laryngeal, that is very inconstant. I should not give you that kind of information because that's not real, okay?
Okay. Sounds great. Why don't I unmute everyone here? Might be a little bit crazy. And if you guys have any questions, please ask. If you'll just stay away from too much technology-specific stuff and focus on anatomy. All right. Stephanie? Or Enrique, I guess you'd say.
Yes, I can hear you.
I had asked a question about, commonly I see surgeons throughout a thyroidectomy, when they find what they think is parathyroid, sometimes they might not even have it tested by pathology, but they'll say, oh, I think this is a parathyroid, and then they have the surgical tech chop it up and they reimplant it. What's the percentage of success rate on that reimplantation?
Sorry, Heather, can you repeat the first part? Because I just heard the last part.
Can everybody mute your own phone?
So commonly in a thyroidectomy, I see doctors take what they think is parathyroid tissue. They may not send it out to pathology to confirm it, but they'll say, oh, I believe this is parathyroid tissue. And then they'll have the surgical tech give them a knife and they'll chop it up into little pieces and they'll reimplant it. What is the percentage of success rate on that in reimplantation?
Okay, good question. Very good question, Heather. And by the way, I'm just basing this in the studies that I review. I put there on the slides the one that says 93%. It sounds to me very, very high because I haven't seen on, long time ago was a lot lower than that. I would say keep it between 70 and 90%. But again, like any implant, it has a lot of variable things. How much amount I'm implanting? Did I create a appropriate sac with a good vascularization? A lot of things may happen, but it is apparently very, very effective nowadays. And there are some ways and some. I've read some articles of descriptions and surgical techniques that are suggested in changing where you're implanting it. But again, it says what I present says 93%. Keep it around 70 to 90%. Okay.
Okay, because I wasn't sure how important that vascularization it was, because you're showing that it's being vascularized when it's already there, but when you explant it and detach that, I wasn't sure how good that was.
Right. That's a good question because, implanting anything as a free implant that you're taking cells and just dropping them there, you need to have the guarantee that you're going to get some vascularization because those cells are not going to float with nothing around them. They need some nutrients. And yes, that's why you have to create a sac where you're going to put that. And that's a very good question, yeah.
Hey, Enrique, will you review, so with a thyroid and a parathyroid, what are the goals in identifying the parathyroids for each of those two surgeries?
Okay, let's say 95% of the surgeries you will see on the field are going to be surgeries direct to the thyroid, okay? And the problem is when you have those surgeries, most of them, you have to resect part of the thyroid. And the parathyroid is attached on the back of it. So what we've seen is that, we have a very high incidence of people that are taking, without not even taking the care of identifying the parathyroid. So you can have this resection on voluntary or of the parathyroid whenever you're dealing with the thyroid, or you can also target the parathyroid. Some tumors that you have on parathyroid might affect the parathyroid, and you have to take them away. So you have parathyroid is exactly like any other organ, and most of the tumors we have on parathyroid are what we call primary parathyroidism, are based on adenomas. The adenomas are the most common tumors, and they create, in those cases, a totally different concept because the patient is going to come with very high calcium levels, is what we call the hyperparathyroidism symptoms, and the patient has a totally different clinical thing, okay? On the other hand, you have second hyperparathyroidism, which are related to time to the kidney. Kidney insufficiency might create a rebound and side effect on the parathyroid, and you can have hyperparathyroidism. But on the other side, parathyroids also can have other kind of diseases, like being, having a cancer or having a dysfunction, and this is when we have hypothyroidism. So you have to balance where is the damage, what I want to do. Obviously, can I preserve this key gland that is basically the sensor of the calcium in my body? Because if not, that is going to be a mess, okay? Taking away the parathyroid is creating a big mess on the calcium level. And these patients are really forever and ever are going to have all the sequelae that you might imagine. Since we talk and we show all the effect that this has.
So you would say in a thyroidectomy, they're looking to preserve it. Parathyroidectomy, they may be looking to confirm that it's tissue that they want to remove. Is that fair?
Right. In a thyroidectomy, and again, I just want guys to keep this concept. Parathyroid and thyroid, okay, I'm talking about those two different glands that almost have the same name. They're located almost in the same position, but they're totally different, and I would say not related to each other. Try to think that embryologically, functionally, and everything that's not related to each other. When you have a disease in one, you don't have to take the other one. And by the way, you have 4 parathyroids. When you have a disease in one of those parathyroids, just take that one. Don't take the other 3 ones, okay? Try to preserve the gland and try to understand that they're totally different, okay? Thyroid disease has nothing to do with parathyroid disease, okay?
Okay. Great. Well, we're at 4 o'clock right now. Does anybody have one last question before we sign off? Anybody?
Stephanie,
right.
what I could do is I'm gonna send you the presentation so they can look around. And guys, text me. I've been getting, questions from a lot of you during this COVID period, and about anything. Remember, let's keep contact with us, text me whenever you have a doubt, and if I can answer it, I will answer. If not, I'm going to jump into somebody that has been with this company longer than us, which is the consultant, that is David Mills, and he probably can answer and has more perspective, has been with this PTI longer than us, and probably he can teach us a lot of things that we might learn through the next month or year. So I'm open. I will send the presentation for you guys, and let me know if you have any questions. Just send me those questions. I'll try to answer the best way. Okay?
Thank you, Enrique. That was great.
Thank you, Stephanie. Bye, guys.
Bye, everyone.
Bye, everyone.
Thank you.
Thank you.